All right, so let's see. Make sure everything's good here. Okay, hey everyone, what's up? I'm here today with, I'm chewing gum.
Wow.
Wow.
If you do that your first year, intern year,
Whoops.
you're probably going to get yelled at for that.
Good thing I'm still fourth year. So, okay.
Take two.
Take two.
Hold on.
Okay.
That's better. Now it can be on your level.
Hey you guys, what is up? Welcome back to another video. I'm so excited that you're here. I'm here today with Dr. Raachelsouthard. He's a DO and he is a specialist in PM&R, so physical medicine and rehabilitation. Little intro about
Hey everybody.
you.
Yeah, I'm Dr. Southard. So I am a physical medicine rehabilitation physician with a subspecialization in interventional pain medicine. PM&R was my primary residency, and PM&R focuses on people who have suffered some sort of injury, and we help prevent that injury from becoming a disability or a handicap. And we can do that through musculoskeletal medicine. We also do that by rehabbing spinal cord injured patients, traumatic brain injured patients, amputees. We write prescriptions for specialized wheelchairs and prosthetic devices. And then we also treat general musculoskeletal complaints. Knee pains, hip pains, everything from headaches down to foot pain.
Neck pain, like I had the other day, if you guys watched that video.
How's your neck doing, by the way?
It's doing a lot better.
Awesome.
So much better. If
Good.
you haven't watched that video, go watch it. He saved my whole neck. We asked you to ask him some questions on my Instagram, so I have them right here. We're going to go through them and just answer some of the most commonly asked questions and even address some of the misconceptions that you guys have about PM&R. So you are a DO physician.
Yes.
Can you explain why DO instead of MD?
Sure. So when I started looking at medical schools, I discovered that the curriculums were the same, the residencies that they do were the same. DOs and MD both do everything from family medicine to gynecology and obstetrics, all the way up to neurosurgery. So I really kind of wanted to figure out, well, what really separates the two? And what I discovered is two things. One, the DO approach to patients is more of a holistic approach. We look at things like if someone comes in with back pain, we won't just take an x-ray and treat the back pain. We will look at work-life stressors, ergonomics in the workplace, especially if they're sitting a lot in their job, especially those people who might be at a desk all day. We look at lifestyle, like if someone happens to be working out a lot at the gym, but not having a lot of direction as to what they're doing properly, that can contribute to these problems too. So DOs generally take a more holistic outlook versus their MD counterparts that traditionally focus in on the disease itself. Aside from that, DOs also have an additional tract of education. So we have additional schooling called osteopathic manipulative therapy, or OMT. So, or OMM, osteopathic manipulative medicine. That's probably the more appropriate term. During our first 2 years of medical school, we have an entire class dedicated to learning OMM or OMT, however you want to call it, that will help us not only treat musculoskeletal diseases, but also help diagnose and treat other conditions as well that OMT can be helpful for. We took all the normal classes that our MD counterparts do, plus we have additional schooling.
And you guys have seen, obviously, that when he adjusted me, he was using OMT to address the musculoskeletal complaint that I had in my neck. It comes in handy, especially for his profession, because you can use that a lot on your patients. I'll be able to use that in OBGYN with my pregnant patients. And so it's really nice to have this extra set of education to be able to help your patients, your friends, family. So.
And no matter what field you end up going in, holding on to that aspect of your education is important, because even everything from family medicine to neurosurgery to OB-GYN, you're going to have a patient that you're going to be able to help with this in one way or the other. So it's important to not just let it go by the wayside after you're done with medical school. You can still use this in your everyday practices.
Our next question is, why PM&R?
PM&R, because it was a more comprehensive way for me to treat patients for musculoskeletal complaints. So one of the things that I really kind of looked for when I was looking into residencies was being able to spend more time with the patients. Inpatient PM&R, you do spend a lot of time with your patients, because while they're between rehab sessions or when they're between their medical treatments that maybe they're in a rehab hospital for, you get to really sit down with them and talk about what's going on with them, because they may have just had surgery, or they're recovering from a stroke, or they have some neurological condition which requires them to be in an inpatient facility. and you really get to sit down and kind of go through everything that they want to tell you about their condition. So I discovered that it was a great way to be able to talk to your patients a lot. And then as I got into PM&R more, I discovered the musculoskeletal aspect was really kind of something I was really interested in, because it allows you to be hands-on. It allows you to be able to not just prescribe, medication here or there for condition X or condition Y. You actually really get to physically examine the patients. So you really get to analyze what their spine or joints are doing to be able to aid in your diagnosis. If you decide to specialize, say in something like interventional pain like I do, then you also get to spend time in the OR, you do procedures, you can do surgeries. There's a lot of things you can do with PM&R. You can also focus on brain injury medicine if you want to focus on stroke care. You can focus on spinal cord injury. There's fellowships in that too. PM&R as a base allows you to go into a lot of different aspects of medicine, with the focus being on, the human body.
And when I was rotating with you, I didn't even realize that you had this whole OR here that you have, and I'll show some footage. We got to see so many different procedures that I had no idea that your field even addresses, and it was super fascinating to see all of the equipment and all the ways that you can diagnose and treat patients. What does a day in your life look like for you?
In the morning, we get in, we kind of assess with the front desk what our day is going to look like if it happens to be on a patient day. So the morning we might have some telehealth. We're following up from various procedures. We may have some new patients or follow-up patients that we have to see in person, because not everything can be done by telehealth and PM&R. We do a lot of musculoskeletal examinations. We also do EMGs. So EMG, nerve conduction study, that's a study where we look at the electrical activity of the body to see if there's abnormalities, like if there's a pinched nerve or maybe like a myopathy that might be going on. So we can take a look at that with this tool. On our procedure day, we'll typically be in the OR all day. We'll be doing epidural injections, radiofrequency ablation, spinal cord stimulators. Recently had a vertiflex procedure, which is this really cool procedure we can do where we insert the spinous spacer between some vertebrae to open up canal stenosis for neurogenic claudication. We don't treat a whole lot with narcotic medications either. So that's one thing we've been able to get away from, because we focus on a lot of our musculoskeletal medicine. We've really gotten away from prescribing any narcotics. I mean, how many narcotics did you see prescribed while you were here for 4 weeks?
None.
Yeah.
None.
It's great.
Yeah. Wow. It's impressive.
And patients love it too.
They do. Dr. Z does actually do a lot of stuff with legal work. And if you want to briefly touch on that, because a lot of you guys don't know about this. I didn't know anything about this or how to kind of get into it. And so can you just describe kind of the stuff that you do?
In the legal field, what is needed a lot of times is a medical expert. And they'll need this because lawyers know law very well, but lawyers don't know medicine that well. So what they need for us to do is to evaluate someone who may have been injured in an accident and be able to evaluate if this person is going to need any kind of care in the future. For example, spinal cord injured patient I really had, who is a T12 Asia A. Sorry, you probably don't know that terminology. They're paralyzed from T12 down. What we have to do is figure out what kind of wheelchair is appropriate for them, because they don't need this wheelchair not just now, but they're going to need a different wheelchair in 10 years. Renal ultrasounds or GI studies, because they don't have the same sensation that you and I do if something goes wrong.
Right.
So we have to account for that kind of stuff and be able to prognosticate that throughout their future.
Is the legal work that's specific to PM&R?
No.
Or can other docs?
All sorts of other docs do. Another aspect of legal work is also medical malpractice. Experts need it for both sides.
Okay.
The side defending the doctor to guard against the standard of care, which is what we call it in the field, because some outcomes are just unfortunate, but they're one of the things that we consent people for. So sometimes they'll rely on us to say, no, this is standard of care. It's an unfortunate outcome, but it's one of the risks of the surgery involved.
Got it.
And then there's the egregious stuff, where you see some people doing things they really shouldn't be doing. And then they also need experts on the other side to say, you know what, I'm a PM&R doc. No PM&R would actually be doing brain surgery or something like that. I haven't seen an actual example of that, but that's kind of what it comes down to. PM&R docs probably shouldn't be delivering babies. So
Yeah, they shouldn't be. And
they should not be delivering babies. So if a PM&R doc's, holding themselves up, they can deliver babies. Yeah, that might be a malpractice thing.
No little babies. Let's see. What are the pros and cons of your specialty?
One of the pros, we get to spend a lot of time with our patients. We get to really be hands-on, and there's a lot of procedures that we do that are immediate pain relief. Ablation procedure is a procedure where we burn away the medial branches to the facet joints. And for people with low back pain, this can be a very effective solution. They get on the table in a lot of pain and get off the table in no pain. And you get to know these patients for a long time too. These patients become yours for decades, if not longer. Pain and musculoskeletal complaints are pervasive throughout life. You get to know their family, their loved ones and whatnot. So there's a lot of reward in being able to connect with patients that well. So some of the cons are, let me think, what are the cons? That's hard to say. There's not a whole lot of cons with it. Sometimes there's a lot of misunderstanding about what we can do. For example, EMGs. EMGs are also done by neurologists. A lot of people don't understand we also do EMGs.
And that kind of bridges us to the next question, which I don't even think you need to address, but a lot of you had a lot of misconceptions and were asking, how is your work different from a chiropractor? And as you can see, all the things that he's talked about throughout this whole video so far, that's your explanation as to how very different being a chiropractor is versus being someone like Dr. Z. How often do you see pregnant patients?
Okay. Actually, this kind of goes a little bit into the con category too.
What?
Well, I'll tell you why. Because of misunderstanding.
Okay.
People assume when they're pregnant, they can't do anything at all. They can't go and get any kind of treatment. They can't take any medications. They can't have any kind of injections. Well, that's just not true. And that's one of the misconceptions about it. For example, we don't want to prescribe NSAIDs in the improper trimester. Of course, Rachel gave a wonderful presentation about that.
Did,
Our
about
student, Dr. Southard, or, at some point when someone's watching this, you're going to be Dr.
Oh my
Southard.
gosh, that is so terrifying.
Yeah. A lot of people just make some assumptions that there's not a lot that can be done, but there can be done. Trigger point injections can be done. We can even do Botox in pregnant patients,
Right.
and not just Botox for facial wrinkles and whatnot. Botox can be administered to people who are having spasms in muscles, torticollis, other painful conditions. So yeah, there's a lot of different things we can do for people who have new pregnant. I do see pregnant patients from time to time, but we'd like to see more because we know we can help them too.
Right, and that was something that I addressed in my presentation that they had us do on our last day of our rotation. Because normally pregnant patients, you just throw Tylenol at them and say, okay, goodbye, you're pregnant, it is what it is, and you'll be fine after you deliver. But that's not the case. They can always get relief, and if you come to a PM&R doc, you can find those different avenues for treatment, because just because you're pregnant doesn't mean that you have to be suffering.
That's right.
So,
and back pain is one of the most common complaints during pregnancy. So.
Right, that lumbar lordosis from baby, the little peanut, the little peanut growing.
Meconium covered peanuts.
We love meconium covered peanuts. Okay, next question. Is being a doctor worth everything you had to do to get there?
Absolutely, 100%. I would have not picked any other profession to enter into if I knew then what I know now.
Okay.
So it actually would reinforce my decision to go into medicine. Because actually initially I wanted to be an Air Force pilot.
Right, I want you to talk about that too.
Oh yeah. I guess this kind of dovetails
do?
one of the questions, what I do for...
What do you do outside of medicine?
So outside of medicine, and I encourage everybody, please go get a hobby outside of medicine, completely separate from medicine altogether. You need the relief from the day-to-day. Especially especially if you're in a high stress field. Obstetrics, when you're at the hospital for 24 hours a day.
Oh, babies.
Babies. One of the things that I decided I wanted to do, since I wasn't going to be an Air Force pilot, I decided I was still going to be a pilot. So I started taking lessons. I actually initially took lessons during college, but I was a broke college student, so I really couldn't finish anything. So between my first and second years of medical school, I went and finished my pilot's license, and then I've continued to get my instrument rating. One of the things I really enjoy outside of medicine is flying.
Going into his office, he has a big picture of I don't even know what it's called.
It's a DC-3 in there.
Okay, that was on the wall, and I was like, that's interesting to have in here. And so finding out what he does for a hobby, I put the puzzle pieces together. How do you cope with stress in a healthy way?
Okay. Well, one of the important things, the thing we just talked about, doing something completely separate from medicine, making sure you can detach, because you need to every now and then. Some of the other things that we do to help deal with stress is breaking up the day. Seeing clinic patients day after day after day after day, while rewarding, can be stressful if you're just doing monotony all the time. So what we do is we do our surgery right in the middle of the week. So that we can break that up, so I can be away from the clinic side and I can be doing procedures and surgeries in the OR which will be something different. So I encourage you to try to do something different every day of the week if you can, even if it's related to your profession. And then also making time to go work out. My wife and I try to work out probably at least 2 to 3 times a week. After work is nice because then you have to be done at a certain time.
Right.
You're like, 6:30 is my class. I'm like, I can't stay late. See ya.
Gotta go.
Yeah.
And that's nice. It's really important. Obviously, you know, going through medical school, even, it's hard to find that balance. And I struggled with that first and second year. But you just have to build it into your routine and make it a habit. And you can carry these habits throughout your life and through residency, hopefully. And then when you become a big doc, and make your own rules so you can still do what you want. So
it does help to be able to make your own
yeah,
rules.
it does. It must be really nice. Can't wait to get there. I have another question for you that none of you guys actually asked, but I personally have a question about it. For residency, I know that you work a lot, but you don't get necessarily compensated a lot.
Yeah.
So did you do anything outside of your residency program to have some more income to help you out?
Actually, yeah. Now, while some of my friends during residency rotated and they moonlighted in psych hospitals doing 5150 admissions, or they worked like in an inpatient facility admitting patients. I was doing my residency at UCLA. UCLA is right next to Hollywood. Figured, let's give acting a try. I actually applied for a role on a small show. It's called Rock and Roll Acid Test. That didn't really go anywhere. Got greenlit for another project 6 months later called 1,000 Ways to Die. They find people who died in various ways, and then they reenact the way that could have led up to their death. I was one of the regular talking heads on 1,000 Ways to Die, describing how these people died and what killed them at the end of the day.
An American classic.
It is an American classic.
I think that's about it for our questions. Thank you guys for asking questions. I hope that this video was helpful. Thank you to you for talking with us today and answering all of these questions.
You're very welcome.
And we are at the Regenerative Institute of
Newport
Beach. Thank you so much.
No problem, Rachel. Anytime. Follow us on Instagram, Pain-Free Dr. Z.
Yes, I'll have it here and down below. And that's all. Thank you so much, guys. Bye.